Okay, we ready? Okay, so good morning, everyone. Today's Thursday, June 25th, 2020. This is a special meeting, but it's actually our weekly Human Resources meeting. Joining us this morning, well, by here in person are Commissioners Brooks and Filios. Joining us by phone en route to Boise is Commissioner Leslie Duncan. Do we have any changes to the agenda?
The request has been made by Commissioner Duncan to do item
1 and 3.
1 and 3 first.
Okay, so we can begin with item 1. Also joining us is Scott Berthart from Alliant. Welcome, Scott, and
Coco Brockhoff.
and Coco also from Alliant. Thank you both. Okay, so we're going to move on to our first business item, and any one of these is a potential action if it comes to that. And item number 1, as requested by Commissioner Duncan, request for training overlap county assistants.
That's me.
Come right up, or grab a mic, but either way.
Are you sure I can't just talk loud enough? I'm just kidding.
You want to scream?
Hi, Commissioners. Ronnie Davison for the record.
Ronnie, yeah.
I'm here requesting a 3-week training overlap. You'll see on the projection.
How many weeks?
3
weeks.
It's 3 weeks. Our claims specialist in county assistance is going to be retiring effective July 17th. She's been with the county for 20 plus years. I think it's like since 1991. And we have found a person that we would love to replace her. However, we just need some more training funds in order to bring her on 3 weeks early because the job is so, I don't know the proper word to use, but it's
Complicated?
Yes, thank you, all of the above.
I know it is.
But we have plenty of salary savings due to a position that we had vacant, and there's going to be quite a difference between the current person's salary versus the salary the new person will make. So we will have plenty of salary savings to cover that 3 weeks. We're just hoping that you will approve it for us so we can have her start on June 29th.
And that savings will actually go into fiscal 21, won't it?
Yes,
Okay.
it will. And it's like roughly $4 an hour that we'll be saving going into 21. So that definitely adds up.
Okay.
What happens if we don't do this?
I won't have anyone to replace her, but it is all coming out of Fund 40.
I didn't ask that.
I know.
What happens?
It falls on just one claims interviewer, which they're both really busy right now
Okay,
anyway.
that's what I want to get to.
Yeah.
Okay.
Yeah, it's too much for one person right now. We haven't seen any of the effects from Medicaid expansion. So right now it's just business as usual, just still really busy, so.
How many years has Carrie been with us?
I think it's been since 1991, so 30-ish.
Wow, 29 years. Okay,
Yeah,
30 years.
she's really looking forward to retirement. I can't say that I blame
I
her.
can see that. Okay. Any questions? Leslie?
No questions.
Bill? Okay, so we're ready for a motion? You want to handle it?
All right. I move that we approve the request for training overlap as presented in our financial projection.
I second the motion. Aye.
Commissioner Duncan?
Aye.
Aye, and the motion is carried. Thank you, Ronnie.
Thank you.
Okay, so moving on to item 3, the adjustment requested in our schedule. And that item is a request to temporarily redistribute salary savings for information technology. Grant, please.
Thank you, sir.
Thank you,
Go
Commissioner.
right ahead, Grant.
I just passed out a handout. Commissioner Duncan, I'll email this to you so that you can get a copy of this as well. And that's basically just a calculation form to show us the breakdown of what I'm going to discuss here. And give it a quick overview. Basically what happened is I have one employee who is out on the COVID FMLA leave, which provisions 12 weeks of 2/3 pay during that time. This is a pretty technical position. I don't feel there's any way to hire a temp during this time to pick up the load that needs to be picked up, which consequently means that the load falls on the other two employees who are doing similar tasks.
Leslie, can you mute your phone where we're picking up the road noise? Thank you.
And basically out of those two employees that pick it up, one is picking it up a little bit more than the other just due to, he has the exact same job as the person who's out. Another one does some of the duties. Basically what I'm asking for is to recover that extra third of salary that would not be being paid during this time, redistribute it to the other two employees for the extra load they're gonna have to be doing. And doing so in a 70% and 30% ratio for those two employees. 70% going to the one who's doing a majority of the load.
And 30%.
30% to the other. So it is a net, it's a level balance for the budget. We're not asking for any additional dollars. We're just asking to redistribute the dollars that wouldn't be expended over this time period.
And how long is the time period? Did you say 3 months?
12 weeks maximum. The employee is not sure based on the conditions whether it would be less than that or not.
Okay.
And what I handed out there is just basically a breakdown to show the total amount and then how that would be distributed amongst the other two employees. That would be the three orange lines there. The top one, this is over an 80-hour period, so $642 for 80-hour period. 452 of that would go to employee A, 195 of that would go to employee B.
Okay. Bill, you're the liaison. Are you okay?
I am perfect with this.
Okay.
Ask Leslie and see what she.
Leslie, are you okay?
Yes, I'm fine.
Okay. So I guess we can entertain a motion. You know what? I can make,
I can do it too.
you want, okay, go ahead, Bill,
I'm
make the
getting
motion.
good at this. I move that we approve the request to temporarily redistribute salary savings for IT up to a maximum of 12 weeks. Does that work? Yes. Okay.
Okay. And I'll second.
Second.
Go right, okay, so Commissioner Duncan is seconded. Go ahead, Tina.
Bill Brooks,
Aye.
Commissioner Duncan,
Aye.
Aye, and the motion is carried. Thank you, Grant.
Thank you, Commissioners.
We're getting pretty good at this remote stuff.
Okay. Mastering remote. Item number 2, final item. Scott Burkhart, Alliant. Fiscal year 21 health insurance discussion, HR. And Scott, I see we have some information here on the limited provider network, but go right ahead, sir.
Okay, I'm just going to start it out real quick.
Yes, Sylvia, please.
Proud for the record. At one of the budget hearings, there was a request to look at the limited provider network. And so Scott, I called Scott right away. He's the subject matter expert, and he wants to give you an update, just some information he's found, and really see where we want to go with this. And so to give you just some more information related to the request. So I turn it over to Scott.
Thank you, Scott.
Thank you. Yeah, so I worked up some talking points here. Thought we'd frame the circumstances and then have a discussion on where we want to go. But basically, the project is to explore and assess the limited provider network option through Kootenai Health as a cost savings opportunity for the Kootenai Health benefit plan. The intent with the limited network is to direct medical services to a limited, more narrowly defined network of providers to achieve some cost savings. So with the limited network, which is a growing concept nationally, there's two basic ways to achieve cost savings. The first is to steer more medical care to a given network and therefore produce more volume for that network, and oftentimes they're willing to negotiate better provider discounts than under the broad PPO network. So that's the first primary way. The second way is to, in accountable care organizations, is to manage care and therefore lower the utilization of services and achieve cost savings that way. So here in North Idaho, there is an existing and established limited network through Kootenai Health called the Kootenai Care Network. And under their model, they're not looking so much at the provider discount aspect. They're primarily solely focused on the managed care element to achieve those cost savings. So that's our, kind of our starting point. We did have a good discussion yesterday with Pat Richardson, the president of the Kootenai Care Network, and they're enthusiastic about the opportunity. And I can start off by saying there is cost savings opportunity through the Limited Care Network, but we'll kind of walk through the rest of this. And we can
Are the savings significant?
Well, that's what I will talk about here going forward. I want to kind of frame what we're looking at. I can cut to the chase and say just a ballpark right
Yeah,
now.
go
When
ahead.
we're looking at the total benefit plan cost, rough estimate would be between 2 and 5% savings. And that was, I kind of worked up some things based on the information that I'll present here in a second. And then after talking with Pat and hearing what they're seeing on their side of things with actual results, matches up pretty well with what I thought could be potential versus what they're actually seeing. Now, we have not vetted the information. We need time to do that. David Smith, of course, would do his thing deeply and kind of vet what they're seeing. But I think with their preliminary number and my preliminary number, I think it's pretty safe to, as a starting point, to say we could see between 2 and 5% savings if we move down this path. But let's see how we get there. Looking at Kootenai County's actual claims data from the last 12 months, there's about 8.8 million in gross paid claims. Okay? So that's your total paid claims number. That's broken down roughly into 2 buckets right now of medical of about 6.3 and then prescription drugs of 2.4 million. Breaking that medical 6.3 number down further, just looking at facility costs, inpatient and outpatient, which is really what we're targeting when we go to a limited network. There could be savings on the professional side, of course, too, but really we're looking at the facility costs that are the big dollar costs. There's 3.2 million over the last 12 months. Now, breaking that 3.2 million down, where's that going currently? 1.7 of that is going to Kootenai Health, and the rest is going elsewhere. 400,000 going to Northwest Specialty, and then the remainder is going to other entities, Sacred Heart, Deaconess, out of area providers. Okay, so I throw those numbers out. There's twofold to throw those numbers out. It currently shows that 53% of our volume is currently inside Kootenai Health. Okay. It means 47% is elsewhere. Okay, so that's kind of the starting point. There is opportunity to steer more care, okay, to Kootenai Health, to that network. The flip side of that is 47% of your employees are currently accessing care elsewhere. So if we go to a limited network, that means there could be significant member disruption. Now, why are those 47% using those services? Some are no doubt urgent, emergent. Some is by choice. We have to remember that Kootenai Health is not always the lowest cost option. Okay, we've got Northwest Specialty, we've got other centers, and depending upon what the nature of the condition is, there could be other centers of excellence elsewhere around the country that are lower cost. So if we explore a limited network by just defining Kootenai Health, we could actually be increasing costs for certain things, unless the managed care component definitely takes traction and manages the overall care to where it lowers utilization. So if we directed, so there's about 1.5 million elsewhere. Let's say we redirect half that volume, because some's gonna stay outside. But if we redirected 760,000, that leaves about $2.5 million we're trying to impact. Okay, not savings, not achieve 2.5 million, but have an impact on that. Let's say we target 10 to 20% savings on that volume over where we're currently at. That's where we arrive at the $250,000 to $500,000 annual savings figure, which translates to the 5%. So that's where the numbers are coming from. I think it's safe to talk about the anecdotal information that the Kootenai Care Network had disclosed to us. They've achieved through their business over the last year on an annual basis, in which they manage Kootenai Health Benefits, they manage Blue Cross of Idaho, individual products as well as Medicare products. They say they've achieved $14 million of savings with roughly 36,000 members in that pool, which would translate to about $30 per member per month
What is
savings.
the percentage?
Well, that's where that number comes. If we look at $30 per member per month, that translates back
The
into the
5%.
5% relative to the
Okay,
Kootenai.
so they're about 5%.
Yeah, so that's where I'm matching up. Well, but it's 5% of total.
Of the 8.8 million roughly?
Yeah, that's where
Right.
I'm translating that.
Right.
If we look at as a percentage of inpatient, outpatient facility costs, it's much greater, right? It's in that 10-20%
Right,
range, looking at your total budget. So that's where the numbers are coming from. Now, let's look at our challenges. I mentioned the Kootenai Care Network's already established, but it's being used for Kootenai's benefit plan, the individual market, and Medicare. It's not currently established for any employer group plans. However, the initial intent when they established this was to roll it out. They're pursuing discussions with Blue Cross of Idaho, which they already have an existing relationship with on the individual. They have not established with Regents, but they've had discussions. Okay, and they actually said they're enthusiastic. They're very positive experience with Regents. Why I bring that up is if we move this direction and if there's no existing relationship set up with Regents, it means we've either got to forge that relationship, work through all the details, logistics of that, or else change our entire claims payer over to Blue Cross of Idaho. Okay, so a lot of potential moving parts, disruption to employees, okay, to explore this. So it's not a matter of just taking something and changing deductible, what we could do over a week, right, with the carrier and the claim system and communicating to employees. It's a pretty big change. Okay, so I set that up to say it would take some diligence and time to properly implement something like this, but it's doable. I mentioned the significant member disruption potentially with 47% of the costs being outside of Kootenai Health currently. Now, the other key thing is this is a managed care concept, okay? Now, that sometimes has a negative connotation, especially with employees who are familiar with the HMO models of the
Right.
past. You know, you're limiting who I can go see, and it's managed. That means I, as the employee, have a responsibility here, okay? Where disease management and managed care fall short currently is if, right now the insurance companies do a lot of the disease management. So when I have a sickness, a serious sickness, and I'm getting a phone call from the insurance company, and I may not want to answer that. I may not want to talk to someone. I'll talk to my doctor, but I don't want to talk to the insurance company. The Kootenai Care Network is the ones managing this care now, okay? The doctor's offices are the ones that are calling. So in that, the model, the concept makes great sense, okay? If Kootenai Health and the doctors can properly manage care and help the employees through that adherence, that could have an impact and be less intrusive on the employees. They're more willing to talk to their doctor. But again, it is managed care, okay? Limiting the providers and the employees, members would have to follow some protocols, okay? I mentioned that they're not always the lowest cost, but overall, that's factored in. I mentioned timing, that it would take some time to thoroughly vet. And I'll just throw out this other concept, and then we can have a discussion. But as we consider moving forward, so there is potential savings. We can validate that. We think the concept is a good one. The question is, are there other ways that we can proceed that are less intrusive for employees and that we can implement quicker?
It will also yield the benefit.
Exactly. And to that, yes, there is. David Smith on our call mentioned that he thinks the better way to go with our benefit plan is steer through benefit design. In other words, ambulatory surgical facility is a good example. David Smith, which he'll present at our July meeting, the statistics and the full analytics on this. But he identified a number of surgeries that were done inpatient or outpatient that could have been done at an ambulatory surgical facility, and we could have potentially saved several $100,000. Okay, so if we're looking at a massive change to a limited network to save $200,000, $300,000, $400,000, if we can achieve that just simply by steering, having better benefits and incentives and employee communication, to steer some of that. That way we haven't alienated Northwest Specialty, we haven't alienated any provider, they still have choice, but there's better benefits if you do X, Y, and Z. So that's one approach. Now, another approach is, could we do both? And the answer to that is yes. But again, to implement the limited network will take more time. We could also ease into that next year. The Kootenai Care Network said they'd be open to a test drive where we could keep our broad network, keep the existing amount of providers, bring in their case management protocols next year, where it's not a massive negative communication campaign to employees, that we could represent this as a positive thing. And we can see how it goes for a while. Let Kootenai Care manage the data, let our analytics team manage the data, let them compare notes, see what's working, what's not working, and see if it makes sense. If we move to a limited network, that's where you're going to achieve the most savings. Okay? But there's a way to ease into that, potentially.
I really like that test drive idea.
Okay. Yeah. And so that kind of sets the stage. And the last thing I'll bring up is, as we've been having the discussions the last several months, is with COVID-19, of course, being the dominant thing. We really feel strongly about minimizing the drastic changes this year. And now, gosh, we're seeing, 23 new cases yesterday. How many in the last week? Yeah, it could be, not with Kootenai County's plan, but here locally, we think that it's coming, and so we don't know what that looks like over the next couple months. So in the environment of COVID, I'd strongly recommend minimizing the changes that could put more fear and concern with the members, employees. If there's a way that we can minimally do things, we'll talk about that in our July board meeting. And then let's see how it goes the next couple months, and we can continue discussions. What I'd like to do if we moved down that path is bring in the Kootenai Care Network and let them just explain their model. If we can get employee buy-in along the way and do this over 6-9 months, that'd be the best approach. Anyway.
Interesting. Bill, thoughts?
I agree. I mean, like I said, it's a simplistic term, but the idea that we could kind of ease into it and, if necessary, ease out of it, right? I mean, and we'll see what benefits it yields, and instead of going whole hog this way.
Great.
Or doing this way. I mean,
Great.
we have to be creative, and I think you think, I get the impression that you think as if it were your company, how would you handle it? And I think you'd probably pick the test drive here.
Yeah,
I'm not putting words in your mouth, but I get that sense that this makes sense.
Yep, fair to say.
Leslie, thoughts?
I'll have more in July. It's kind of hard to hear. I do have Scott's notes here, so I was able to follow along most of the time, but I'm just saving my questions for July.
Okay, fair enough. Yeah, this is fascinating. And I think what you hit on over and over again that resonates with me, Scott, is the single word, disruption. And what concerns me about going to a limited network is limited options.
Just like that,
Yeah, and not only that, they're no longer in a competitive situation. So how far out do those savings actually accrue? That's a concern that I have, but a test drive wouldn't be bad. I don't know how much the test drive will reveal. But again, I think hearkening back to your point, with everything going on, with COVID cases increasing, why would we want to impose any disruptions at this point? I'd also like to hear, Sylvia, you have any thoughts you want to share with us?
And I agree, we need to take it slow. I think we still need to look at a legal review with the concept, and can we sole source from a government entity perspective, making sure we're not hurting Northwest or any of our partners that we have on board with us. Education of the staff's going to be critical as we ease into this. I'm a big proponent of that because the more they understand, the greater success we'll have with implementation on it. And take it slow. COVID has really disrupted everyone's lives and caused some undue stress that if we just make some minor changes to our plan for 21 and really potentially doing that test drive, but 21, during that time assessing it to see, is this really going to work for us as a county?
I know when I was the health administrator for a hospital, we would have the major employer. In this case, it was the phone company that had 400, 500, 600 people and a union, and they'd come in and say, we want some better pricing. Because if we can't get better pricing, we can go down the road to the nearest hospital. Is there any of that goes on here?
Yeah, in North Idaho, that's one of the dynamics. It's the key dynamic in healthcare because we've got one primary health system, Kootenai Health. And Northwest Specialty is a great facility, but they're not full service.
But what about the valley? I mean, the valley is, you go to Portland and you drive from one side of Portland to the other, and that's about what we have to drive to go to any one of the major hospitals. And
That is the next option, is to send people to Spokane, and that concept just, it does not go over well here in North Idaho, sending people out of
Right.
area to Spokane.
may go over well, though, in negotiations.
Well, I can let go. That
Do you want to jump in here, Carl?
yeah.
Please, no, I'm-
It just, just being straightforward, the threat of moving volume to Spokane, I don't want to put words in Kootenai Health's mouth, but they would say, okay, good luck with that. So, I mean, really, I don't mean to be flippant, but
No, that's fine.
Here in North Idaho, that aspect. Now, if we had another health system, or if we were over in Spokane, absolutely. But there's we have a unique environment, a unique geography, and culture here. That border is pretty firm both ways. I mean, people from Spokane generally do not come over to North
Yes,
Idaho
good
for
point.
care. People from Idaho, it's somewhat split. Some do. Like, I have to take my son over to the pediatric endocrinologist. I have to in Spokane. So there's a little more going that way. But in terms of negotiating and saying we're going to cut out Kootenai Health to get a better deal, they kind of know we can't realistically do that. So it doesn't go far in terms of a negotiating for price.
It seems to me, as you said, Kootenai's costs are not only not the lowest, they're some of the highest in the area.
Well, and not in all services. They are
not
actually,
in all.
yeah, they are actually lower. Now, we know overall, and this is just looking at the basic analytics, we know they are lower than Spokane on most services.
Okay.
Yeah, so we have an advantage there. But here locally, on some services, they're not. And if you get into more specialized services, yeah, you can go to Seattle and get lower costs on some things, even than Kootenai Health. You can also get costs that are 2 or 3 times more, depending upon the service. That's what makes this so complex, and we got to be really careful about it. It'd be nice to say Kootenai Health's always the lowest cost, but it just does not
the
work that
case.
way. It's by procedure, by specialty, and then there's total care package when you bring in the professional side and the ongoing management. That's kind of what we're looking at. So what we do, if we wanted to, from Kootenai Health, we've tried this over 20, 30 years, different ways in bringing major employers to Kootenai Health and say, so let's say we bring 750 employees, 2,000 members to them and say, okay, here's our members. Well, right now, we're accessing the pricing through the pool of Regents Blue Shield of Idaho, which is tens of thousands. Same thing with Blue Cross.
That's what we're doing now.
Yeah,
Okay.
so to pull ourselves out of that and say we're the major employer in the area, they're like, well, okay, that's great, and we do. They do want to work with us. They're willing and enthusiastic to say that is awesome that you're willing to come to us and we want to work with you, but we're not going to lower our contract pricing, generally speaking, just based on that volume. Does that make sense?
Yeah.
And I hope I wasn't flipping with
No, it
any of my
does.
comments.
It does.
No. Fascinating. So we're going to go into greater detail mid-July. David's going to be here or participate?
Yes, we're gonna look at some opportunities for savings. I mean, we've got the deductible, and all those things. We've got a whole matrix already prepared, but our goal is not to go there on the general deductible, employee contribution.
Right.
What we want to do, our recommendation is that, especially with a modest renewal budget 4% increase, we'll show a couple options that could be savings opportunities, steering traffic to like the ambulatory surgical and any other opportunities that he can see. And then we can decide how disruptive is that? Is it worth it? But we can at least have a good discussion, and he'll have all the data surrounding that.
Good. This is a
Okay,
great
cool.
thing you've
Good discussion.
Thank you.
Thank you, Scott. Thank you, Coco. Appreciate it.
Okay, thank you.
Public comment. Leslie, are we okay to use your stamp?
Yep, no problem.
Okay, thank you. I'll ask again, public comment? Anybody want to chip in, contribute, anything? No? Okay, 11:32, meeting adjourned. Thank you, Coco. Thank you,
Thank you guys
Scott.
very much.